Are we on? Hello, my name is Eric Prosher and I represent Jesse Brown VA Medical Center, and I have a special guest from our medical center. Her name is Asia Brodsky, and over the next 25 minutes we're going to be talking about one of her specialties, which is sexual health. And so this is a live call and interactive program brought to you by Can TV 21. And so we invite you to call in with all your questions as we talk about veterans and sexual health. And you can call us at 312-738-1060. Our lines are now open, so come and give us a call. Asia, thank you. Thank you for coming on to the show.
Absolutely.
It's a very important topic, I think, that a lot of people don't necessarily know about it, but probably people have ideas about. So today we're going to dispel some myths and educate the population out there, and talk about your important role at Jesse Brown VA Medical Center.
Thank you, sure.
But before we do that, why don't you tell me a little bit about yourself and how long you've been at Jesse Brown VA Medical Center, located on 820 South Damon Avenue, and what your role is there and what your training is informs the work that you do with our veterans at Jesse Brown.
Sure. I'll be happy to do that. Let me start off with a disclaimer to say that sexual issues are hard to talk about and not often discussed.
Yes.
The more we talk about it, the more comfort we get in discussing them, and I think it only enhances care.
Yes.
So for people watching and might maybe experiencing discomfort, use this experience to gain more comfortability and start to have the conversation.
That's right. Take a risk. Call us today, right now, with your questions.
So I started at Jesse Brown 3.5 years ago. I started in the homeless program, but I have transitioned since then to mental health, to outpatient mental health. And so this is where I'm able to practice sex therapy, which is my specialization. I work here with individuals and couples. I also run groups. And as I will talk about today, the sexual work is very multifaceted. Sometimes we're dealing with issues of sexual dysfunction. Other times we're dealing with mental health diagnoses that are affecting someone's sexuality and sexual expression. So it's very varied in the work that I do.
Cool.
I started in the field several years ago. In the field of sexuality, I sort of gained an interest in this during my undergrad career. I was doing research on several different identities at the intersections of those identities, looking at males who are HIV positive, who are also identified as bisexual, transgender, or gay. And so we were looking at the intersectionality of those identities, and I was on the back end transcribing interviews, and I was realizing that there's a way to do direct practice work and talk to people about the sexual issues that they have. And so I ended my undergraduate schooling and I decided to pursue a degree in social work and decided to tailor my experiences specifically in the realm of sexuality. My first practicum was doing HIV work. My second one was doing rape crisis counseling. And I joined ASECT, which is the American Association for Sex Therapists, Counselors, and Educators, so that I could specialize, develop my certification, and go from there.
Great. Wow. So why don't we start off with the big $1 million question. What is sex therapy?
Sure. So it's a good...
Why don't you come just about an inch
Sure.
closer? There
Sure.
you go. There you go.
So sex therapy is a specialization within general outpatient therapy. So it's therapy practiced on a outpatient basis, and it is a subset of treatment that focuses on sexual issues, sexual expression. Sex therapy is done with individuals and with couples typically, because typically when someone is exhibiting a sexual problem, it is not in a vacuum, it's not in isolation. They're dealing with this with a significant other.
Yes.
And the term is confusing because, again, we don't talk about sex and then people start to think, well, what kinds of things happen here?
Well, we live in a repressed society, but however, like advertising and pop culture are infused with, sexual innuendo and, teasers and...
Absolutely. Well, and I joke in saying sex is everywhere except sexuality, right? Because while it might be everywhere, we're not talking about it,
That's
and we're
right.
doing a whole lot of assuming
Yes.
of what do people like sexually, what do people do sexually. As a matter of fact, that's a question I get very often: is, am I normal? Is the behavior that I'm exhibiting completely out of line, outside of a spectrum? And then I have to ask, well, what is normal, and what's sort of the measure that someone is using to assess their behavior or function?
Right, and do you have an answer for that? Because I just remember in my readings a long time ago that Sigmund Freud's, characterized the human condition as polymorphous perverse. In the
Yes.
sense that we get pleasure from all different ways and sources and types. And,
Yes.
so it kind of, is there a normal?
Well, I think, the way I address this question or comment is we go by the patient's idea and definition of what normal is, right? Because people have certain expectations, and part of the work is understanding what are those expectations? Where does that come from, right? What is the meaning behind what you're looking to answer?
Yes. So understanding those expectations means, in part of your study, kind of understanding the culture that we live in and the norms and,
Absolutely.
and the influences there that impact people's behavior.
Right. Well, and I think too, sexuality changes over time. And so
Yes.
the issues that will affect a young person, sort of someone's self-esteem, what do my peers think around sexual behavior, intimate behavior, bonding even behavior, would be very different than a teenager who's sort of more self-aware around their identity, more focused on more specific sexual behaviors, understanding sexual functioning, early sexual experiences, reproduction, to more later in life where we're looking at coupling and uncoupling. We're looking at the effects of medical conditions, disorders, age, and how that plays into functioning. I will sometimes have, when I work with couples, people will come and ask, I don't understand why I've lost my sex drive or why I have a diminished libido, and then they'll say to me, I take care of 2 little children, and then I come home, and then the answer, right, you're exhausted, and so the answer makes sense, and it's much less a matter of normality and much more of expectations and what are the surrounding contextual factors impacting whether or not someone's able or interested to maintain a sexual experience.
Yeah. So you mentioned low sex drive. Are there other common concerns that, or what are some typical concerns that people seek professional help for? In the area of sexual behavior.
Yeah. So when I'm seeing couples, a lot of the issues that arise will be factors such as desire discrepancy, meaning there's a difference between the drive or interest of one partner in comparison to another. And so we assess that. We determine what could be influencing someone's drive, what do they expect for themselves, and what does their partner expect of them. That would be an issue that I will see in couple presentations. I will also see factors such as experiences. So in the veteran population, there's a very high amount of military sexual trauma. In the more general population, there's a high amount of sexual trauma. And how does that affect sexual functioning? Whether that impacts whether or not someone's interested, whether someone is very reserved or avoidant, or really inhibited in their ability to enjoy sexual experience, or connect to someone sexually, to really understand what is it like to connect to someone. When I think about optimal sexual experience, I think about the ability to lose oneself with another person and allow them to hold you sort of psychologically and maybe even literally through an encounter. But that requires a lot of trust.
And vulnerability.
And vulnerability.
And these are the things that are destroyed after trauma.
Absolutely, absolutely. And so it's working to address those issues to then allow that to translate to the sexual experience, and work it from there.
Great. I'm just going to pause there for those of you at home that might have just turned on the show. We're here with Asya Brodsky, and she is a therapist and staff member at Jesse Brown VA Medical Center, and we're talking about sexual health. She's has a specialty in sex therapy, and she works at Jesse Brown VA Medical Center. So call in with your questions at 312-738-1060. So, where were we? So sex therapy with veterans with the veteran population, which may have a higher exposure to trauma, including military sexual trauma. Do you see there are differences in terms of how you would approach a veteran in your sex therapy?
Sure. So I think we can't undermine the role of military culture when it comes to presentation. A lot of the people that I see, especially men, have certain views around the way they should act or be or conceal their sexual problems, which they internalize as signs of weakness or signs.
It's kind of like the traditional masculine values of self-reliance, stoicism, suck it up and drive on, emotional control, independence.
Absolutely.
All the very things that might make them a good sailor, soldier, or airman in an operational war zone, but actually come back and cause problems in relationships and even mental health.
Absolutely. And I think for a lot of those men, they're suffering in silence, because we don't talk about sexual issues, we don't really address them. There isn't really an outlet to say, I need help with this, right? It's just not part of the conversation. And so then the work starts with building safety, building trust. One of the things I mentioned earlier with sex therapy as it not being a very well-known thing is, we work within the ethical confines of the profession. So for me, I happen to be a social worker, so that's following the standards of social work. For others, it's within those confines. But it's maintaining trust and safety. Touch is never an element of the work that I do. It's turned to,
I'm glad you brought that up because some people in popular culture, there's Masters and Johnson was that HBO or Showtime, one of the series that I guess there were early pioneers in sex therapy, but they actually had like a lab, and they weren't even like, one was a physician, but they weren't psychotherapists.
Yes, yes. Well, and I think, Masters and Johnson is sort of, when the layperson thinks about sex therapy, they tend to think of Masters and Johnson. And so Masters and Johnson studied the sexual response cycle. They wrote their book, Human Sexual Response, in 1966. And they sort of studied sex in a lab. And it was very mechanical to understand how does sexual functioning work. And so they developed the sort of the measure of excitement, plateau, orgasm, resolution. And so now when we look at sexual dysfunction, we tend to, or at least previously, this is changing a little bit more now, we used to diagnose sexual issues based on sexual response without much recognition to the fact that there's additional experience to sex besides just mechanical physiology. And so then Helen Singer Kaplan came into the picture. And so she started to understand and sort of explore what is a psychological element, considering more desire in the aspect of excitement and arousal. But the thing with Masters and Johnson is it sort of set the stage for a very linear, goal-oriented sexual experience, where you engage with a person and this is sort of how it goes. But the reality is there's a lot of factors that influence whether or not that can be created or recreated. Right? And so we have to consider, well, is the focus on an orgasm or is the focus on pleasure and actually sort of feeling connected with a partner, allowing yourself that kind of an experience with somebody?
Yes. So intimacy.
Yes, absolutely.
So would you say, are there differences in male and female sexual arousal and cycles based on I'm not sure if the Masters and Johnson, was that based on a male model, or was that generalized to all women, or is there, how's that work?
That model is sort of used for both sexes. The only thing that's different that is sort of typically incorporated is the refractory period, the idea that after an orgasm, a male needs time to be able to have another sexual experiences versus a woman who does not. But nowadays, we veer, certainly sex therapists, certainly certified sex therapists, and I should add that that term is not controlled. The only place where certification is sort of regulated is in the state of Florida, and so it's very important for people to be able to find someone certified to know sort of what someone is, that someone has an expertise. But nowadays we focus more on other models. Instead of looking at a goal-oriented linear model, we look more at circular models and models that look at someone being spontaneously aroused versus responsively aroused, and how does one's sexuality play into another person's sexuality, and again, how do we create a satisfying intimate experience versus a goal-oriented one where perhaps the pleasure of both partners is not being considered.
Right, and even within that model, I see there's diversity, right? The sexual experience can come from arousal, it can come from neutrality, it can come from a responsiveness to arousal.
Absolutely.
And
Absolutely.
so with all those differences, how do you measure progress in sex therapy?
Yeah, so progress can be hard to measure because we're looking at something very open-ended and something that changes over time. So I think one of the ways I start out with patients is sort of trying to understand what is their goal and what is making them seek help now, right? So oftentimes I would say there's a precipitating factor to why someone is seeking help. Perhaps their relationship is on the rocks. Perhaps they've realized that their way of relating sexually with other people is detrimental to them or to the other person. And so we measure progress by figuring out, what are they looking to achieve? Are they looking to achieve satisfaction? And if yes, what does that look like? Are they looking for something more measurable, such as frequency? I'd like to increase the amount of times I have sex. Or are we looking at something that's a little bit harder to measure, like I'd like to develop comfortability with my body, which has to do much more with self-esteem, which has to do with, longer term work. When sex therapy sort of developed, it was developed as a brief intervention, very much focused on homework assignments, practice this. Masters and Johnson were famous for sensate focus, which is touching exercises, developing comfort. It's very much about mindfulness within the sexual experience. But again, we look at what is someone's goal, and is this an achievable goal? Sometimes, I've had patients, and especially within the veteran population, where there is such a complexity of issues that someone is dealing with when it comes to experiencing sexual pain and working through their identity, and also experiencing physical trauma that's affecting them. What we're really looking to do is, how do we expand the repertoire of what is it that someone is doing, and how can they still experience something exciting for them and feel satisfied from that experience?
Okay. So for the veterans at home, what can they expect? What do they see you individually? Do they always see you with their partner? Or take us through maybe what a veteran might expect when they come to the VA.
Sure. So if a veteran's coming to the VA and they're specifically looking for sexual issues to be addressed, then they would be, once they're referred, typically through the psychiatric assessment clinic or through a provider who knows that there is a sexuality.
So it could be through the primary health care doctor can make that referral or a consult. But if not, the Jesse Brown VA, 820 South Damon Avenue, we have a psychiatric assessment clinic on the first floor. There's some phone numbers if you want to try to get appointments there. And what would happen?
And so typically, if someone is referred, whether it's through PAC or through a consult to see me, during a first intake session, it's generally typically similar to another psychotherapy appointment, where it's their time to tell their story. And I will say that to patients. I'm working to develop comfort. I'm working for them to develop trust and ability to really address what it is that they're dealing with. I'm trying to understand what are their goals for treatment? What are they looking to achieve during their time? Do they have a time frame? I've had some people come in with very specific time frames around, I would like to address this in several months. And then we have a realistic conversation about whether or not that can happen. I will see people individually, and I will see people as a couple. I see all different kinds of constellations.
Okay.
So dyads, whether that means parents and children, helping cope and understand and experience whether sexual or not, to groups, to one-on-one talk therapy.
Great. Are there common barriers that you see in addressing sexual health issues with veterans?
Absolutely. I think, so like I said earlier, people really don't have they're not comfortable talking about these issues. And so it's our job to permit the discussion to build that level of comfort. I think so often providers are scared that they're going to offend someone by asking a sexual question. They feel like they don't have the time to be able to dig into someone's sexual history. I mean, today's sessions, especially medical appointments, are so short that they're trying to get through what's pressing for the patient and really don't have the time to address the sexual element, even though the
That's
sexual
a good
element,
point.
right? Even though the sexual element might be really, really important to a person.
Yeah.
But that person won't bring it up unless we sort of start the conversation.
Right. So is there any recommendations you have for the veterans, what they would need to know before they came to their first appointment with you?
I don't know if there's anything they would need to know besides coming in to allow for the conversation to happen. And if they can't have the conversation because they're shy or embarrassed, to sort of feel the space out. I very much believe that we should not continue to work with providers that we don't feel comfortable with. And so feel the space out, see how it works, to allow for a discussion.
It sounds like you're about empowerment.
Absolutely,
right?
absolutely. Yes.
And increasing the choice and agency of your...
Absolutely. Well, and I also think so much of we have such a high amount of negative experience, what I call big T's and little T's. Big T's, people usually think of big traumatic events impacting a lot of their life, but there's also little T's that are sort of benign neglect, if you will, where experiences that don't seem like they were that damaging become really detrimental to someone, and then that plays out, right?
Yeah.
And so figuring out what is that? What is the meaning of that to somebody? How does that play into what it is that they bring to the table?
Right. So, I work with post 9/11 veterans in our TCM clinic, and mental health is probably the second most common concern for veterans coming back from deployments. And many of those issues can be addressed through talk therapy. Many veterans also utilize medications. Are there things that our veterans should know about medications and that impact on their sexual health? You watch the television, you see the ads, and there's like
Absolutely.
a whole list of side effects, and usually
Absolutely.
sexual, like impotency, is
Yes.
a common side effect for some medications.
Yes.
Are there certain medications that you see more often in your clinic than not, and what do you do in that case?
Yeah.
Some veterans might come in, this is my mental health or my sexual health.
Absolutely. And and typically mental health and any other element of health gets prioritized over sexual health. But I think there are known medications. There are antidepressant medications. There are some antipsychotic medications that are sort of known to inhibit sexual functioning. And it's being able to have a conversation with your provider and say, this is important to me. I'd like this to be addressed. I would like this to look different if that conversation is able to be had. But again, I think our job is to sort of give agency, because oftentimes patients won't bring up these issues because they're afraid, they feel embarrassed or prudish to be able to address the fact that their sexuality is important to them. It's on us. It's on us to have that discussion.
Well, Asia, I can't believe the time got away from us, and we didn't get any callers today, but I want to thank you for taking your time and sharing with us your immense knowledge on the issue of sexual health. We represent Jesse Brown VA Medical Center. I'm Eric Prosher. This is Asia Brodsky, and we'd like to thank you for watching CAN TV 21. And you can learn more about our organization. You can learn more about getting involved with mental health or getting involved in sexual health at Jesse Brown VA. We have a call center, and you can ask to be patched to talk with Eric Prosher is my name. I'm a psychologist, and Asia Brodsky is a social worker. And that number is 312-569-7225. So please tune in again. We're going to be back here fourth Thursday of the month, of next month, and for you, those at home that need to talk to somebody and you're in crisis or you need some extra help, well, we do have a crisis line where you can talk with someone, a live person, 7 days a week, 24 hours a day. All you have to do is call 1-800-273-8255. That is 1-800-273-8255. And then press 1 for veterans if you want to talk for veterans. But this line is open for everyone. So thanks again. And if you're at the Jesse Brown, stop in and come see us. Goodbye for now.